Hey guys, this is chapter 20, Management of Anger, Aggression, and Violence. Starts on page 296. It's about 15, 16 slides here. Shouldn't take too long to get through. Anger, internal affective state that may or may not be expressed in overt behavior. Anger becomes maladaptive if it's too frequent, too intense, or managed in an unhealthy way. It can actually lead to coronary heart disease, metabolic syndrome, and MI, suppressed anger. Your book talks about a lot of people learn how to suppress their anger, and that's just as bad. We shouldn't suppress it. It can be related to arthritis, breast and colorectal cancer, chronic pain, and hypertension. So there's a lot of different things that anger can lead to, kind of like stress, which we talked about in chapter 19. There's different styles with how we express anger. It's in table 20.2, which is on page 298. And this talks about the anger suppression. It talks about unhealthy outward anger aggression and then constructive anger discussion. So discussing the anger with a friend or family member to talk about the anger. I thought this was interesting. Your book said good nurses do not get angry at patients, and we shouldn't get angry at patients. That would include like coldness and distancing. Maybe you're mad at someone for being difficult, and you start being cold and distant towards them. Patients want steady, dependable, confident caregivers who will remain connected with them when they are angry. People who are in the hospital typically aren't in a good state of mind, right? They don't want to be there, so we need to work with them. Assessment of anger. So you have outwardly directed or inwardly directed. It's difficulty in regulating the frequency and the intensity of the anger. Is it causing problems, maybe at work or within relationships? These are all things we need to assess with the patient. How is it affecting them? And could it be an underlying psychiatric or mental disorder? Your book talks about culture and gender considerations. As far as anger goes, I believe 297, so back a page, they do have some cultural myths in box 21. So Western cultures generally promote more aggressive behavior in males and more, I don't even know how to pronounce that, conciliatory behavior in females. Generalizations may not apply to marginalized individuals such as ethnic minorities. Eastern cultures completely disapprove of anger for both genders. You guys know, I mean, even in class, you can tell that just like with stress, we all deal with it differently, correct? And same thing is going to be with your patients. So what are we going to do for these individuals? Well, I mean, the number one goal is to take them out of the situation if possible. Avoid provoking stimuli, stimulus control, response disruption, relaxation training. If you've ever seen, when I was reading through this today, I was thinking of all of the movie with Will Smith, Bad Boys, and I think it's Martin Lawrence, and he goes to therapy, and he always has woosah and pulls his ear. That made me think of that. So relaxation training. What can we do to relax? Anger management. There's didactic and experimental. This is for dysfunction, but nonviolent anger. So this can be done in groups with a teacher and a coach, not typically a therapist. So aggression and violence can command the attention of the criminal justice system as well as the mental health care system. So aggression involves overt behavior intended to hurt, belittle, take revenge, or achieve dominance and control. And violence is extreme aggression. So know the difference between those two. And factors that can influence aggression and violence behavior, that's going to be depending on the patient, right? Depending on what they're going through. But a lot of different factors can increase that. Aggression is overt behavior intended to hurt, belittle, take revenge, or achieve domination and control. That was in the last slide. So they could be verbal, like sarcasm, insults, or threats. Think about how that could be online too. It's a lot easier. We got these keyboard heroes. Physical could be property damage, slapping, or hitting. Impulse aggression occurs in situations of anger and anxiety when the individual lashes out. So know the differences in these terms as you go through. Violence is known as extreme aggression, use of strong force or weapons to inflict bodily harm. It could be to kill. All violence is aggression, but not all aggression is violence. So make sure you understand the difference there in aggression and violence and the vocabulary words that go with it. Again, safety is always our number one priority. It's important to work towards these goals by developing good nurse-patient relationships. So if this is going on in a clinic or in a hospital, maybe you're in a mental health unit, it's really important to have those nurse-patient relationships. I think you guys have been working on that at the Pavilion and at Sarah Bush and at Palm Terrace. I mean, you've learned that to sit down and talk to someone, try to develop a relationship. And it's hard because you're not there very long. But that's what they're talking about, making a good relationship so we can work on that. Creation of a therapeutic milieu. I'm not sure if that's how you pronounce that, but that is your book goes back to this term several times. So this is a structured environment that creates safe, secure place for people who are in therapy. So a structured environment that creates a safe, secure place for people who are in therapy. I don't know if you're seeing that. If we were in class, I would ask that. Do you feel like where you're at when they do therapy, is that a structured environment that creates a safe, secure place? I would argue in the movie that we're watching that it's not always safe and secure. We saw that this past week when he busted the glass, right? And during therapy, there was so much drama over the cigarettes and everyone just kind of went crazy. But obviously that's not the standard today. But I wanted you to know what that means, because as you read through your book, they refer back to that term several times. How do we assess for aggression and violence? Can you tell from clinical what patients could be aggressive? Can you, I know when Jamie was here from Sarah Bush, she said she always kind of knew who to kind of be looking over her shoulder at. Or when you're at clinical, do you have people that you're suspicious about that you've been around that are like, oh, maybe something's off? History is the most important predictor of potential aggression and violence. The physical condition, so like long-standing alcohol use, maybe they have increased irritability, disorientation, paranoia. We haven't really talked about schizophrenics, but schizophrenics a lot of times have paranoia. Social factors that may tip off about aggression and violence, maybe they're in financial or legal trouble or have conflict with other patients. So can you tell at clinical who the aggressors are as you go through your day? I think that's something that you'll probably get better at. Again, nurse-patient relationship is really important. We want to avoid those power struggles. And I've heard you guys talk about when you're talking about clinical that sometimes the nurses don't do that maybe. And sometimes they are just really more aggressive. So we want to stay away from that and avoid those power struggles. The book goes on and on and on, and I put in capital letters in my notes, listen to the patient. Validate the patient's feelings. That's really important. This must be scary for you. And so on. When possible, provide choices. I know sometimes that's hard. We've talked about maybe lunch trays. Someone maybe wants a chocolate milk instead of a water or whatever. But if there's an opportunity to provide choices for these individuals, that can allow them some sense of control over the situation. Providing patient education and developing prevention strategies. It's really important. Your book says to seize those teachable moments to convey important principles on anger management. When we reduce stimuli and create a culture of nonviolence. De-escalation, there is a book about this, but this essentially means talking the person down instead of challenging or provoking. It's not important for us to be right in these situations. We don't want to escalate the situation. It does talk a little bit, you want to try to clarify what's upset the patient and get to the bottom of things. Your book does talk about PRN medications, administration and monitoring. However, it didn't give any examples. If we were in class, I would ask you what you've seen given as far as medications to calm them down. I think we talked a little bit about this last week, and we talked about Haldol, maybe something else. We really want to avoid the use of seclusion and restraints if we can. The last part of this chapter talks about responding to assault on nurses, which I think is really important. And I think this really became an issue probably between more of an issue, I guess I should say, during COVID. I think there was a lot of issues here, but it's always been a problem. This has always been an issue, but I think it even became more of an issue. There are assaults with immediate and long-term consequences. There is a table in your book that talks about this. Page 309, nurses' responses to assault. Okay. Assaults can be wide-ranging from verbal threats to minor altercations to severe. Regular training programs in prevention and management of aggressive behavior, mandatory workplace violence prevention. This has become big the last several years. To go to, I don't think you have to get it for your 20 CEs yet, but typically there are some requirements, especially depending on your work, where you're working at, especially like ER, where you would probably have to go to or take a class on assaults on nurses and what to do in those situations. That is chapter 20.